How can mobile technology help eye surgeons and their patients? I'm Loren Butler. This is the iViews podcast from iNews. Thanks to the sponsors of the show, Mainline Instruments. They provide unmatched service and unbeatable products in eye care technology. But just a reminder, this podcast is editorially independent. So I'm delighted to be joined by Iain Livingstone. Iain, would you be able to explain to our listeners who you are and where you're from, please?
Sure. I'm a consultant ophthalmologist and I work in a district general setting in NHS Forth Valley. And we do a lot of general work, but my specialism is inflammatory eye disease and I also do some neuro-ophthalmology. But my research interest, I guess, or the thing that is my burnout prevention part of the week is when I work on mobile technology and technology generally in patient pathways.
Well, that's actually one good question I was going to ask you later on is actually about burnout and physician burnout. It tends to be increasing. But let's go back to what you first said about AI technology. How can a smartphone aid an eye specialist and their patient?
Well, I mean, I've had my head in this sort of space for a very long time. I started working in this when I went to the senior ophthalmology rota as a registrar, and suddenly we had to look after children. And I thought to myself, I'm not going to know what the hell I'm doing, but the one thing that I can do well is extract a vision from a child. And I was getting into a bit of trouble for breaking into orthoptic departments until I had the brainwave at that time of scanning case picture tests, which is the standard that I was used to for children that hadn't learned to read yet. It's the standard test that you'll use for kids 18 months on. Scaling it on my phone, making a PowerPoint presentation type slideshow that I knew was scaled accurately, and at least I could get a vision. And I thought this could help others. Let's make it an app. I had a chat with my brother and he said, there's this thing called IP you should probably learn about. And I picked up the phone and spoke to Hazel Kay, who's still a lifelong friend. And she said, quite sympathetically, she'd had a chat with her son who worked for Google and it was niche. It wasn't going to make any money. You know, this is back in probably 2009 or thereabouts. And generally, he thought it was a terrible idea, but she thought it was a good idea. So we worked on it together. We brought out an app called Eyesight Test, which was CE marked, I think one of the first. And that's how the sort of saga began. And for me, when that came out and I experienced seeing people that I didn't know using it, that was so affirming. You know, that really, I was in it then, you know, that was the moment. And that was reviewed by a colleague in London School of Hygiene and Tropical Medicine who was looking at the incidence of blindness across the Rift Valley in Kenya. And I was sort of suddenly working in a team and we founded Peak, which fantastic developer called Stuart Jordan brought out the tumbling e-test, working in his own time, philanthropically, you know, following these eye specialists. And my colleague Mario Giardini, now at the university, he made an incredible retinal camera that worked on a smartphone that allowed someone with zero experience to extract a beautiful, and this is right up your street, a beautiful picture of the optic disc. And suddenly we were mobilising the eye clinic and we did transatlantic retinal exams. And we then sort of moved into the space of using sort of peer-to-peer video conferencing to allow that flow of information. Really having my head in that space when the pandemic landed, we were quite fast to mobilise a decision support service across optometry in Scotland, or certainly in central Scotland. And suddenly we were in the public health space. You know, there was lockdown, patients weren't coming to hospital, we had a decommissioned bunch of consultants, and the Scottish Government took over 3 premises across NHS Forth Valley, matching the population. And So one optometrist for every 100,000, basically. They made sure they had all the kit that they needed, from Optomap through to video slit lamp. And the eye casualty was suddenly spread across the community. And we had 7 consultant ophthalmologists who were all at the end of a video call, and we were seeing stuff as complex as we'd ever see in the eye clinic, but now we were helping optometrists or helping our patients, and every case was a teaching case. I mean, it went too far in the other way, because I can remember 3 consultants all scratching their heads or pontificating over a dendritic ulcer, but it was a brilliant peek into the art of the possible, and I've kind of had my head in that space since.
And getting that symbiotic relationship between high street optometry and secondary care too as well, and building on that and transferring those skills must have been so important too as well.
The technology is what it is, and there's not been a massive transformational change in the tech, at that moment, but it was just the ability to join these dots. And I think the sort of slight wartime mentality to get things done allowed us to do things that we perhaps couldn't do with previous governance structures and so on. And of course, the major part is having consultant availability in an unprecedented way, so a very unique situation. But yeah, the thing that really mattered much more than the technology was the relationships. It was very much an ethos at a very scary time of you throw it, I'll catch it. And the optometrists absolutely did. And so, yeah, continued focus for me has been consolidating on that and really trying to maximise that link between community optometry and secondary or tertiary care.
And how are you consolidating that, and how are you maintaining the relationship between primary care and secondary care? Because it can be quite siloed at times.
It can be very polarising, and it's very different in one territory to another. I'm fortunate to work in an area that doesn't have a massive proportion of moving optometrists. The people who are in post. It's not. We have quite a dispersed, in some places fairly rural area. So I think we're in a good place. I think the things that I'm doing as a team, we're doing to try and make it better is increasing the amount of independent prescribing that we have locally. And now I'm very involved in simulation for training in that space with NHS Education for Scotland. And I think this ethos of see one, do one, teach one is kind of a bygone time now. I think now it's a case of do one virtually 100 times and then hit your first real one with great expertise. So that's my hyper focus for the moment, has been creating really immersive simulation materials that really don't just focus on a clinical sign, but really go right back to the history and how we can wrap AI into that to really have a virtualized end-to-end presentation to management structure. But to answer your question about relationships and how to maximize that, I think the best thing that we can do in secondary care just now is look after these independent prescribers post-qualification, because having a fairly intense period of seeing lots of things in hospital does not guarantee using that potential effectively in the community when you only see an anterior uveitis 3 times in a year, and sometimes we have an illusion of success. We measure things that are easy to measure, and the stuff that's hard to measure is kind of thought not to exist, but is often the most important thing. And I think that's very true in this space, because you can have a patient that's not escalated to hospital because they're managed in the community, but if they're seen 20 times more frequently, that's not a good fiscal proposition, So it's getting that balance and the reality of the differences in training of a doctor versus an optometrist, the attitude to risk, the comfort with uncertainty, being able to accept what you don't know and be at peace with it. Know that you can let a patient away and you might be making them worse, but having the safety netting to know what worse looks like so you can rectify and correct.
And I think that's very important, the safety netting, and sometimes that really isn't as transparent between high street optometry and secondary care. We don't have that kind of, stewardship that sometimes we would like. Going back to how you started, was it just a method to relax and kind of decompress, and a burnout kind of strategy you're having to get away from the pressure of day-to-day clinical work?
You mean the focus on digital tech?
Yeah.
I'd say it came from a place of being a first consultant on call and really reaching for something that wasn't there, and therefore trying to make it. We are a really unattractive proposition for a lot of people in Forth Valley because you're the first on consultant. You don't have juniors out of hours. It's you that's getting up to see that angle closure. And you are busy. You're the man on fire for the time that you're on call. And you have a very intense week. But the kickback is you get a week off afterwards to try and decompress. And that combination worked well for me because when you are, certainly for me, when I was outside my comfort zone and adrenalized, that's where the good stuff happened. The mother necessity of needing to have an eye in multiple places at once to safely manage the people on your patch. That's where enabling optometrists to dial you into their video calls with slit lamp views suddenly changed things. And it made it so much more interesting. It was affirming for them. The cases became training cases. If they called you about a couple of marginal keratitis or small ulcers, they actually didn't call you with the same question for the next one that came in. And I remember observing a colleague, Andrew Ferguson, good friend of mine. I observed him taking a call from a community optometrist. And he said, oh yeah, it looks like it's a small ulcer. We wouldn't scrape that. So you're a prescriber, go for Exercin. Let's make it 2 hourly for the next few days. And he said, and we'll see it back. And then he caught himself and he said, well, actually, there's no point in us seeing it back. Why don't you see it back in 5 days or so? And if it's not staining and looks better and the patient's comfortable, you can taper off the antibiotic and discharge them. And if it's not, just give us a call back. And so with that 1 5-minute call, 2 appointments were saved. And that was quite an intoxicating thing to be part of.
You were letting go a little bit, perhaps?
Absolutely. Well, I don't feel at all grippy or threatened by these cases being managed elsewhere. There are important, deeper questions to ask about what does this mean for our juniors who are no longer seeing these as much, And I had a fascinating term that I hadn't heard before, which I'm going to take a minute to make sure I get it right. Enabled helplessness. If we are at the end of a call all the time, we have to stop doing something to pick up that call. And if we are there and over available, we're not really helping the community optometrist develop that autonomy that they need necessarily. That's where it comes back down to relationship, experience, and zooming out a bit, and the unintended consequences of this type of work. But while I hear all these criticisms, generally, I think as a service, a crucial part of what ophthalmology do is giving robust decision support and answering the call for help when it's there.
Going back to you observing your colleague, giving that information to the high street optometrist, did you learn anything from it?
Well, yeah, I mean, my instinct would have been, you start the treatment, I'll see them back, but what he'd done was enabled a situation where that patient never crossed a threshold from community to hospital, and the whole thing was captured in the community, which is better for the patient, which is better for the optometrist, I would say, and in a saturated service, it's better for us too.
Time for a word from our sponsors, Mainline Instrument. Leading in ophthalmic innovation since 1997, Mainline Instrument supplies premium ophthalmology equipment from global manufacturers, including eyecare, Oculus, Tord Pi, Tomei, Optomed, Hewitt and Needs. From advanced diagnostics to surgical solutions, explore their products and services or book your in-clinic demonstration at mainline.co.uk. Mainline Instruments. Unmatched service, unbeatable products, unrivaled quality. And we're all interested in patient-centred care and very patient-centric focus. What do you think the impact of mobile technology has for the patient?
One of the things that we did, we were really going for a big way to leverage mobile technology, and NHS in Scotland procured Attend Anywhere. I was relabelled NHS Near Me, and that was made completely despite us and was there and being used ostensibly in the Highlands for patients to connect with medical teams, through a hyperlink. And it existed outside all the hospital infrastructure. It was super agile. And we just piggybacked on that. We rolled that out to the optometrists, so they started the call as a patient, but actually rather than a patient looking into the camera, it was the optometrist's equipment looking through the microscope at the eye. But also, it's surprising how many things you can deal with when it's just patient to hospital as well. And I had, a guy with a cavernous sinus fistula, and I could tell it was an orbital problem when he was at his couch after being dialed into a video call by an optometrist. And he went straight to the scanner, straight to the neurosurgeons, didn't even hit the ophthalmology department to have that fixed. And he was really grateful. Never met him, but came in with wine. That doesn't happen often, and I think a lot of our present practice is about our comfort zone. We're so used to having a patient in front of us, but it's not necessarily in everybody's interests. But when you are trying these new things, you got to know where the gaps are, and you got to be the biggest critic of the service. And there are lots of gaps. We gave the same technology to our emergency department, and I can remember thinking I'd done a great job with a high FEMA, being able to see it beautifully, even visualize the pigmented cells being cascaded. Patient was quite comfortable. I thought I'd done a great job, brought them back the next day because they were very young, and the pressure was about 45. That one bit of information that I didn't have was the most important. So, yeah, it's not a panacea, but for me, and certainly with the job that we had to do, it enabled us to do a lot more.
Do you find your colleagues are uptaking as much as you are with AI technology? Or are you getting any pushback?
That is a really pertinent question, and it is a totally polarising prospect. And there's not many people that are in the middle. There are people who absolutely love it and lean in, and there are people who it's just another distraction on top of an already saturated service. And that piece of interrupting people and how you carve out time for unscheduled care, we've not got that right. And I think that for that reason, uptake was less than what I would have liked it to have been. And it was probably out of 7 consultants, although there's times that we've all used it, I would say it's less than half that really consistently leaned on it. And as time has gone on, the only thing that amazed me about how much it helped our patients and how much it caught on and is how much it's bounced back to not being used. And I think that's a reflection of the increased pressure on the service. Might be the jaded prism that I'm looking through. I don't know. But certainly we are using it less now than we were before the pandemic. So we've definitely not got it right. And I think that's the challenge. The technology is a massive enabler, but if the job plans don't change around it, that there is a huge opportunity cost. And what I've observed is these video-first services. I had the pleasure of spending some time with Gordon Hay and his team down in Moorfields, looking at how they work. And what they've achieved with, certain parts of London, when somebody picks up the phone and phones 911, at the moment the call handler says, go to your nearest emergency department, they now have the option to say, I'm going to connect you to an eye health specialist. And being a fly on the wall in these consultations and seeing these people who are being looked after albeit through a video call, after a 20-minute wait in a video queue with them in their own house, and comparing that to maybe a 9-hour wait in the emergency department, which is what it might look like, there are areas where it has really caught on and appears to be working. And how we take the best bits of all that is still to be worked out.
That's my next question. Obviously, collaboration, seeing what other trusts are doing, but obviously Scotland is way ahead of the curve in lots of areas in optometry and ophthalmology in comparison to other areas of the UK. Would you plan to roll this out maybe further nationally?
My dream for this is a real protection of time to be available for unscheduled care for all the calls that are coming in for Scotland. Having a team of video-first ophthalmologists that work across boards that can look after the Highlands and Islands and places where it's really needed, and be able to step in and be in a senior opinion right at the start of a journey. What might take us 3 minutes could save a patient, a helicopter transfer and 12 hours. But again, how you roll this out as a reasonable part of a consultant job plan when the pressures are what they are, where, every minute matters, I think that needs work. And I don't know how to fix that particular problem.
Is this something that you want to continue doing, or do you find it's taking more of your time and commitment and energy to put into it?
Well, it's absolutely something that I want to continue doing and contributing to. I think the biggest part that's getting a bit of traction now from this work is the remote testing of vision. So when we were doing these video calls, we could see the pathology, but we wouldn't know what the patient can see. And a focus of recent work has been allowing a vision test through a smartphone remotely. There's lots of players in this space, and the Scottish Government, I thought, were quite forward-looking in the way that they approached this, and rather than have an eye department try and invent the future, they asked us to define a problem statement. And the Small Business Research Initiative programme put, at that time, £100,000 out to generate a competition to get, as a call to arms to companies, to make a remote vision testing platform. And that was great because that connected really agile companies with our orthoptists. And if we had one condition where it really mattered what the acuity was, and a remote assessment could avoid an appointment, it would be amblyopia. So working with Sally Painter in Birmingham, Ruth Hamilton in Glasgow, and Jennifer Skillen in Fife, we did a multi-site evaluation of remote vision testing in children, and they were aged from about 2 right up to teens, but the average age was in that amblyopia population area of between 6 and 8, and or sometimes even younger. And we did demonstrate that the mean difference in acuity from a home test and a hospital reference standard is about 2 letters on a line, if that. But what matters are the limits of agreement, and what is good enough. And I think from our work in this space, we are in a place where we can actually move towards a blended model of children being assessed at home. But not only the children at home, the orthoptists can also be at home, so clinic rooms are saved. The carbon footprint decreases, missed school decreases. And then the next bit is, well, the platform has been procured, now we need to start getting the job plan into shape to get that into practice, and that is the tough bit. Proving it works, that's not hard.
As you said, I think there's an awful lot more apps out there in the space, and I think one of the important things is getting it clinically validated. And with so many players in the market, if you're talking about the Orthoptic Society and Optometrist Society, the RCO, do you find that'll be difficult to try and tick all the guidelines, tick all the boxes?
Well, that's a good question. I mean, because we were looking at amblyopia specifically, and it was during the pandemic that we started really looking at this and evaluating it in a trial. The Royal College of Ophthalmologists and BIOS were quite forthright in saying that no technology should be leaned on that hasn't been properly evaluated, which is utterly reasonable. But this was happening at a time when all routine business was cancelled, and amblyopia follow-up is routine business, and we missed a generation of kids who had vision that could be better. So, the unintended consequence of not being perfect meant harm. And so I think taking a pragmatic view and viewing the guidance as that and doing what you think is best is always the best way forward. But I think there are CE mark technologies that are now above reproach to use in this way. And in places like Addenbrooke's, they're already using Digiviz, where parents are checking their own kids' vision, and that's been a part of their service with excellent work by Louise Allen and others. So there is a precedent, and I think we're past that point now.
And are you forthright with your patients about the use of technology and AI?
You have to be utterly transparent. I mean, I think a lot of what we've talked about is much more about leveraging mobile technology and video calls, but I also use AI every day. And I think you have to know where the holes are. You have to be the biggest critic of it, and you have to take complete responsibility if you get behind something that's wrong. But I think you are disadvantaging yourself as a clinician if you don't use it. And a friend of mine at the Royal Society now, Jay Verma, I can quote him, and hopefully I'll get it right. He said, AI won't make you, won't replace a doctor, but it will make you a more competitive doctor than your colleagues. And I think that's true, because the amount of information that it can process at your fingertips, I do think you're now at a stage where you're disadvantaged if you don't use it.
One of the things as a clinician we tend to get with lots of experience is intuition. And sometimes in that kind of video call, telehealth, telemedicine, you don't get that intuitive kind of interaction, the rapport with your patient. Do you find that difficult?
That's a really interesting thing that you bring up. So we have a lot of mid to late stage career orthoptists in our team who tolerate me with these technological innovations. And one of our orthoptists who reluctantly agreed to do this, she deliberately didn't tell me how our first video call went, until I was face to face with her. And she said to me, for all the trepidation that they had about doing it, the thing that surprised her was not, that it was accurate. We didn't know the results. It was actually the preservation of the rapport. It was actually the fact she could have a laugh with that child. The fact that she knew them and she felt that bit, that there's so much fear around losing, was not lost. Having the end user being connected with the company to get all those things right was really the magic. Again, it's much more about relationships than the tech.
Yeah, and bedside manner is one of those kind of, intangible things you can't measure. But, some clinicians, some professionals have a fantastic bedside manner, some are, may not. And that tends to be really, really paramount to get that kind of rapport with your patient too as well.
Absolutely. People don't remember so much whether you were right or wrong, but they remember how you made them feel.
Correct. They remember the impression they gave you. Yeah. Going back to burnout. So sometimes people tend to go into side hustles or interest because of burnout in work. Was that an area that you felt that kind of you wanted to kind of do as well? Did you find that kind of work was becoming all encompassing? You wanted to release elsewhere?
I don't know that I kind of thought about it as explicitly in those terms, but I think it's a tough gig and it's quite unremitting, and it is a marathon and not a sprint. And I think I heard a colleague use that expression of Burnout Prevention Day, and for him it was research. And I think whatever your sort of flow state is, if you're lucky enough that that's cataract surgery and that's also what you do, then, good for you. But for me, it's probably doing something a bit more creative, something that leans on creating digital pathways, new ways of thinking, new ways of working, and that intoxicating piece of seeing other people using something that you've contributed to, that's the burnout prevention bit for me.
That's the reward, isn't it? Yeah. If we talk about some of our listeners who will be listening to this podcast and they may have an interest in AI but don't really know where to go next, would you be able to signpost them to a couple of resources that maybe you found informative, you found educational?
You know, people think AI is a big thing to learn, and I completely relate to that. And I feel it even as someone who I'd class myself as a bit of a technologist. You know, I have a weird sense of trepidation when I look at X and see the latest thing that I know is going to consume my hyperfocus for the next few hours, and all the unintended consequences that has on family life and all that sort of stuff. Yeah, so it's a big daunting thing. But actually, the technology is now in such a way that people can now create without even looking at code. And vibe coding is an expression that's now been recognised as a word of the year or expression of the year in the Collins Dictionary. And vibe coding, it was one of the chief engineers at Tesla, I think, that coined the expression, where you're vibing, you are describing what you want, and AI is making something for you, and you are telling it the good bits and the bad bits until it's in a shape that you like. And it's like having a conversation with a expert team of developers. And I think we now live in this world where a reg who wishes something existed to help them can now go home, spend a few hours making it, rapidly prototype it, and potentially even having a usable shape in an evening without having to do a computing degree or anything else. So I don't think there's a better time, to be interested in this space of making new digital tech in healthcare.
Perfect. Thank you much, Iain.
No worries.